I really was brought to palliative care within the world of nephrology by treating patients. I realized very early on in my training when I was a fellow that I could spend so much time learning how to write dialysis orders and solving problems of sodium and other things related to the really fascinating physiology of kidney disease, but it still would lead to me feeling as if I weren't doing my job when I went to the patient's bedside. And that was really because I saw so much suffering when I was treating patients with kidney disease. I saw patients who were in pain. I saw patients who were nauseous. I saw patients who had uncontrollable itch. I saw families that were in so much distress about how ill their loved ones were, and just looking and searching for some way to refocus the care on the person.
What brought me to this work really stems from my experiences as a nephrology fellow when I was doing basically 100% clinical time. And what I noted was that when I would go to the hospital and do my inpatient rounds, so many of my patients who had kidney disease were ending up in the ICU. And I go to the ICU and, I'd have these discussions with the healthcare team, with the patients and their family members about the type of care that we would recommend and what they would desire. And what became increasingly apparent very quickly was that many of the patients, in particular the patients that had some type of chronic kidney disease or end-stage kidney disease, had never had these discussions with their family members, with other medical team members about care that they would want at that moment.
What brought me to this set of activities was that I was chair of Network 5, where the end-stage renal disease network, where this activity began some years ago, led by Nancy Armstead and Woody Moss. And as chairman, I was supportive of utilizing some reserve funds to start the project off. My support for supportive care, or my commitment to supportive care, was the recognition that there was a major need for supportive care services to patients with kidney disease failure, both CKD patients and patients on dialysis.
I began my nursing career in dialysis, but I also worked in hospice for a short time early on. I went back to dialysis. But some years later, the manager of the hospice company reached out to me and asked, "Hey Lynn, what's your referral process for dialysis patients to hospice?" And I didn't really know how to answer. We didn't have a process.
My experience with my grandmother's death brought me to this work. My Amma, my paternal grandmother, Amma is what I called her, was living in Toronto at the time while I was completing my internal medicine residency. And I got a call one day that my grandmother was very ill and that I should come and visit. I was dumbfounded when they said, "No, you can't talk to the doctor." It was 6:30, 7 p.m. I'm sensitive to the fact that, people are probably at home, not asking for them to come in, but just to inform our family so that we could have a better sense of what was happening. And the next morning, shortly after she had died, the new doctor came in and just kind of put her head down and just mumbled, I've not met your grandmother before. I'm just here to pronounce her. And it was just such an experience of lack of empathy and just a lack of recognizing the loss that had just occurred for another fellow human being.
And so when I heard about this Pathways project and its vision, it immediately reminded me of this conversation that I had. And that's when I knew this was an opportunity change within our culture.